or Indian population. It's a prospective study. We just discussed about many actions of these antibiotic drugs. Again, aspirin and clopidogrel have become standard therapy in patients undergoing percutaneous coronary intervention with stenting. There is considerable heterogeneity in response of individual patients to each of these drugs. Resistance to antibiotic is associated with adverse clinical outcome in post-PCA patients, especially stent thrombosis. The aim of my study is estimating the prevalence of aspirin and clopidogrel resistance in Indian patients. It is a prospective descriptive study of 151 consecutive patients undergoing coronary intervention. All patients were aspirin and clopidogrel for at least 5 days. All these patients are excluded from the studies, like hemoglobin less than 10, platelets less than 100, creatinine clearance of less than 90, and concomitant administration of drugs not to interfere with the metabolism of clopidogrel, like omeprazole, and smoking patients, and patients who had reoccurred. Statistical method, we used SPSS 11.0 is used for statistical analysis, and sample size calculation done by according to biostatics criteria. Chi-square is used to find the association between sensitivity of aspirin, clopidogrel, and selected variables. Study protocol: all patients received aspirin and clopidogrel as per guideline. Platelet function test was done between 5th and 10th day after angioplasty, and platelet function test done by point of care verifying now analyzer. The verifying now aspirin assay uses arachidonic acid as an agonist to measure the platelet function along this pathway. It reported as reaction unit of 350 to 700 units. The values more than 550 aspirin reaction unit shows inadequate aspirin action or aspirin resistance. In case of P2Y12 inhibitors, verifying now uses ADP as an agonist to induce platelet activation and ascertain the level of impairment. It has the ability to retrospectively estimate the base platelet activity before thenopyrine administrations. Results available as platelet aggregation unit. Higher PRU more than 213 or lower percentage of inhibition less than 20 are indicative of clopidogrel resistance. According to, based on these findings, our research shows that our cohort data shows that there is high preponderance of male patients of 84.8% and female patients of 15.2% out of 151 patients. According to age distribution, younger patients are significantly large in numbers in Asian population presenting with acute ischemic heart disease. Nearly 54% of patients are less than 60 years. There is equal number of diabetic patients in our cohort. We found 27.2% of the patients are aspirin resistance. And their relation with the gender, there is overwhelming response of female patients showing 39.1% compared to male patient 25%. But this difference is not significantly statistically significant. Regarding their response with the age response, less than 50 age patients are 17.2% of the patients, and more than 70, 25% of patients differences. But again, these findings also not significant statistical significance. Then the relation with the diabetic patients, diabetic has no influence on aspirin sensitivity in our cohorts. 33.8% of the patients are showing clopidogrel resistance, and their relation with the gender showing large number of female patients are resistant to clopidogrel. These differences of clopidogrel resistance with the male and female patients are found to be significant statistically with a p-value of 0.001. And their relation with the age, less than 50-year patients are showing 24.1%, and more than 70 years, 45% of the patients are resistant to clopidogrel. But this difference also not significant statistically. And interesting to note that diabetic patients are more resistant to clopidogrel than non-diabetic patients. With 40.8% of the patients are resistant to clopidogrel, diabetic patients are resistant to clopidogrel, and 26.7% are non-diabetic are resistant to clopidogrel. But statistically, it's not significant. Then aspirin and clopidogrel both resistance. 7.3% of the patients are showing resistant to both aspirin and clopidogrel. With these are the patients we should watch very carefully in the follow-up period for development of clopidogrel. But preferentially change these patients' drugs to more potent antiplatelet drugs like dasugrel or ticagrelor. Our study showed the prevalence of aspirin resistance in 27.2% of the patients, even though younger patients less than 50 years showed low incidence of aspirin resistance. This was not statistically significant. Diabetes in no way influenced the platelet reactivity to aspirin. And clopidogrel resistance we found 33.8% of Indian population, significantly more common in females, and similar findings were reported from other countries. More common in diabetic subjects, statistically not significant. Many trials reported significantly higher incidence of clopidogrel resistance in diabetic subjects. And also more common in elderly patients more than 50 years when compared to subjects less than 50 years, but statistically it's not significant. Clopidogrel resistance involves both acquired and genetic factors. It's a prodrug. It's transformed to its active metabolite by CYP450 enzymes. There is genetic polymorphism reported by CYP2C19 expression. CYP2C alleles are *1, *2, *3, *4, and *17. *1 allele shows normal enzymatic activity. *2, *3, *4 reduced enzymatic activity, but *17 showed increased enzymatic activity. Depending on ethnicity, 32% to 55% of persons harbor CYP2C19 *2 allele. The Gravitas sub-study GIFT trial showed that high residual platelet reactivity was increased 11-fold in homozygotes and increased 62% in heterozygotes for the CYP2C19 *2 gene compared with non-carriers. The Cannon and Brown world mentioned that polymorphism in CYP2C19 occur in approximately 30% of the whites and 50% of the among Asians. There is variable number of studies are showing variable clopidogrel resistance of 30, 40, and 25%. And our study also showing that incidence of clopidogrel resistance is comparable to other international studies. So in conclusion, there is no increase in clopidogrel resistance among Asian or Indian population when compared to other countries, and there is high preponderance of clopidogrel resistance among women as in other countries. Elderly population appears to have high clopidogrel resistance but statistically not significant. Diabetic population also appears to have high clopidogrel resistance, again not significant statistically. Thank you.
Thank you very much. This paper is open for discussion. While we're waiting for the questions, 65% of the females in your population were resistant. Do you actually make an attempt to do something for that? If you know that 2/3 of the people in your population are going to be resistant to clopidogrel, are you going to prospectively alter the dose, change to a different drug, or do something else?
Yes, sir. When we find this resistance clopidogrel, we are electrically changing this patient's drug to prasugrel. If patients are affordable patients, we are changing to ticagrelor and educated patients.
So I assume you routinely examine or verify now each of these individuals how soon after the loading dose or how soon after therapy starts?
We are doing this platelet function test post-PCA patients, pulmonary coronary intervention patient, on 5th to 10th day of the post-PCA period. After confirming their good platelet inhibition by antiplatelet drugs.
Have you found, like in the previous presentation, increased aspirin resistance among the clopidogrel resistant patients?
We didn't find that that differences compared to clopidogrel and aspirin. When compared to aspirin, clopidogrel is more resistant than aspirin drugs.
And what was the maintenance dose of aspirin in your cohort?
150 milligrams.
150. And any more questions?
Does this patient have 7% of the patient who had dual hyporesponsiveness, right?
7.3%.
So the issue, I think the chair also pointed out, was there any factor which will point out that these are the patients not going to respond to aspirin and Plavix or clopidogrel?
We could not find the exact reason why these patients are not responding to aspirin and clopidogrel together. But all these patients are aspirin and clopidogrel at least 5 to 10 days. And we could not find the exact reason differences.
So since 2/3 of the patients were also hyperresponsiveness, it is probably likely if you are hyperresponsiveness with clopidogrel, probably maybe to aspirin too. Like we concluded. You haven't looked at it. Thank you.
You're all on an excellent paper.
Do these patients have clinical adverse events? Hyperresponsive. Do clinical adverse events?
Yeah, we had six patients presented with after post-PCA incident thrombosis. All these patients are resistant to clopidogrel, less than nearly 20% of.
That's 60% of your patients.
Six patients.
I know, but 60% of your patients was Anderson's hyperresponsive. How many percent of they had essential?
6%.
No, how many percent of those who was hyperresponsive
Yeah,
had stent thrombosis?
it's 25%. 25% is our patients. We found 33.4% of the patients of resistant to clopidogrel. We had nearly 15% plus patients presented with instant thrombosis.
But not all of them.
Yeah.
That's
That's
not
why
all of
we are doing all these patients are platelet function test and changing their drugs to more potent drugs.
So may patient be hyperresponsive but don't have stent thrombosis?
If you intervene and change therapy based on you may not
What did you do for that 60% female that was hyperresponsive?
We will change this clopidogrel to more potent drugs, pursuprel or ticagrelor.
Dr. Vijayaram, that's the same question I was going to have. In our series, Dr. Sharma presented the same thing. The large number of patients are far more dynamically resistant, but clinically speaking, I'm not sure that translates into clinical unresponsiveness. Like you stated, a few percentage of patients are coming back with stent thrombosis. That raises a lot of questions. Do we really need clopidogrel in all these patients? If you do need, and they're hyperresponsive, do we really have to change them to prostaglandin or the other ticagrelor? So maybe you don't have to. So there's a huge number of questions you're raising right now. You may like to pursue that same study, take it to a different level. Now check for the clinical responsiveness. Stent thrombosis maybe some kind of stress test or something to see whether there's any thrombus or like some kind of problem there.
Thank you very much for an excellent presentation. And I think it's easy to say, let's go to clinical outcomes, but you have to realize that the trials that look